I would just like to ask from the delegates out here, how many of you really have done a femoral neck system or a neck fracture? Except the people, cushioned people. I think that let me tell them first, then we can discuss it rather than discussing it amongst ourselves and what is the benefits or the things. That's why I wanted to know that at least the people will know what we are discussing if we are at least telling them. This is a fracture, which is a vertical neck femur fracture. So what are the options available to us? And if I can ask from the panelists also, in your experience and your mind, what are the factors on which the outcomes of the neck femur depend if it is like? This is the fracture in a 50-year-old male. What are the things which define or decide in your mind the prognosis for this patient? Yeah, so if I can just see the fracture, the patient, and the implant. So let's discuss about these three major criteria we want to discuss.
So the outcomes are dependent on only few things. One is the initial displacement, how well you could reduce it. So the most important factor is your reduction. And the third, the stability of your fixation.
Okay, great. So that finishes most of the things for me. And I would go about saying that for the people out there, remember this movie, RRR. And this is what the outcomes of neck femur depend upon. Reduction, quality of reduction, and the maintenance of reduction. So it's all 3-3-3, reduction, reduction, reduction. And how do you qualify that? Quality of reduction, as Chetan has very rightly said, the three: quality of reduction and how you are going to maintain it till its union. So, sir, let's go back again to that fracture and then see what is our implant of choice for fracture in your hands.
I would use a DHS with parallel screw.
DHS. Anybody for CC screws out here? Show of hands for the people out there, delegates and all. Nobody? DHS with derotation screws. What are the rest of the people going to do? That's the biggest question. So we just, to cut the story short out here, I would say that read this paper. If anybody out here, this is a JOT paper of 2022, a multicentric group of them having 492 patients at trauma centers. The base, their OTAs, young femoral neck fracture working group results. This will totally change the things and the outlooks which you see. And they have discussed the failures as non-union, osteonecrosis, malunions of more than 1 centimeter of shortening, and subsequent surgeries. In a displaced fracture, if I can ask the panelist in a 50-year-old person, what is the expected rate of failures in your hands or what in your experience? Dr. Sushrut, Dr. Tanna, other people, okay, everybody.
Percentage wise?
Yeah, roughly. Not accurate, roughly. Your experience.
1%.
Dr. Tanna, sir? You replace them straight, sir.
30-40%.
30-40. Dr. Sushrut?
25%.
25. Anybody from the audience out here? Yes, Nitin? Percent. Vinder? 30 to 40. Rajiv? Yeah. Overall incidence of failure is 45% in America. They are not talking of the duration from the injury to the surgery. They are doing it within 12 hours to 24 hours. All these patients, people out here. Imagine displaced fracture neck femur is 51% failures. And undisplaced is 20%. This is from the best of the centers in the world. 492 cases which they have done. Just for an opening, I'm not discussing thing out here, but just to create that we are discussing regarding complications, but a primary neck femur when it comes to us. How much is the complication rate in the best of hands in most of the people? which we are not looking. 32% went major reconstruction, 23% non-unions and rest, and 20% conversion to secondary TH. And mind you, these are all young fractures. These are not patients above 55 and 60, which we are not. These are of patients of young fractures of neck below 50. And these are the risk factors which they could find. Poor reduction, chronic alcohol abuse for them because the patient might be walking, or the bone quality, fracture combination. For the audience, multiple screw construct use as compared to a fixed angle device. TC screws were not the best of implants for them. The ratio of failure is pretty high in them as compared to with an angle stable or a fixed angle. Just for the out here, I'll just leave it. And these are the problems. Another paper with CC screws or the
Dr.
vertical.
Vivek, is there a statistics where it says fully displaced fracture, well reduced if needed by open reduction with the blade with the DHS and one screw? There all the problem is very markedly reduced. Is there a statistics like that or no?
No. Open reduction of fractures in the world is not. There's only one major paper which is there of
If
tolerance.
needed, there is never a primary open reduction.
No, out there in America, many of the patients and many of the centers do a primary open reduction for all cases. So that's why they have a paper which is many times quoted, which says that in which they have shown that open fractures, where you reduce the fractures, they have higher complication rate. But it will happen in our centers also because they are complicated cases. That's why we are opening them. So this is a fracture. In CC screws, you put in partially threaded screws or fully threaded screws. Both of them can fail. DHS is still considered to be the best implant in neck femurs with a derotation screw. But it has some failures. And for you, the people out here, the FNS, which I was supposed to discuss was this, is that its biomechanical stability is considered to be equal to DHS. It has an anti-rotation screw which is inbuilt in the bolt. It is not having a lag screw, it is having a bolt. It is something, a modification of a DHS for the people out here. Having a locking screw which is 1 hole or 2 holes. And you can do it in a small way with an easy surgical technique. There is no lateral protrusion up to 2 centimeters, unlike DHS. They have slightly modified that as compared to a DHS. Okay. And you do it in the same way as you do, reduce the fracture first, holding K-wire, then 130-degree guide wire, which is center. And then you put in the screw, lock it to the shaft first, and then put in your anti-rotations. And this is how you can get the fixation. It is a miniature DHS with a derotation screw which is inbuilt. To cut the story, that's a simpler version of a FNS which is there.
The other screw which is at the angle, which they presume to be, it will avoid a collapse after the first thing has been fixed up. It is presumed to be their intention.
Yeah. It's holding your rotational stability. The anti-rotation screw which is there is holding the rotational stability in the anterior-posterior plane. But if you see in the lateral, they are in the same plane. So they will allow the collapse in similar lateral when it has to have collapse. If you see in this.
So, sir, the bifurcation gives that rotational stability, and the varus collapse is prevented by the width and strongness of the hip screw, main hip screw.
The bolt.
That the bolt is for the
Bolt and the barrel and
avoiding
the
varus collapse.
angle stability of the fixed angle blade, fixed angle implant. So this was the fracture which we had discussed. I'm just showing you some cases that yes, it also can be fixed through an FNS, and I'm showing our experience with this. The critical thing is reduction. As was said, you reduce that fracture properly, and then you put in the screw, perfect lateral and center, just like we do for any DHS. This is the final view. You can see that it is centered, placed. The reduction is as good as we can get. And that's the post-operative film of that. You can see that fracture. This is right fracture, vertical fracture, which we were discussing. We had seen in the beginning. That's the incision for that. And in lateral view, it is perfectly centered. And at 7 weeks, you can see that we have started weight bearing for him. And it is holding. The collapse which happens with the CC screws is not there. And just like DHS with the derotation, this is a miniature DHS with derotation with slight advancements, which can work a good bone stock for us. Worldwide, there is a paper by Peter Giannodis in April 22 in International Orthopaedics of 100 patients of FNS with 3 months of follow-up, and they analyzed the worldwide literature of 380 cases. But remember, out of 3 months, the reoperation rate was nearly 9%. It is not up to 6 months also. But the age is 63 years as mean. They are talking of slightly elderly population also, where they are fixing with FNS and getting the failure rate as this. And the factors was again surgeon's experience, which is again related to reduction, and precise placement of implant, which is again related to reduction. If we look at real literature, it is reduction which matters. The fixation still works. I'll show you some examples. 51-year-old with no major comorbidities, again a vertical fracture. Fixed. You can see the 6 months follow-up. The collapse is not there. It has united. Just a case like this, sir. What is your choice for this? He was having this Enders nail put when he was a very small child or something like that. PPRP patient, post-polio residual paralysis. We had to remove this Enders. We couldn't do it. It was stuck inside, so it broke in between. But here the implant of choice was nothing for us. Because where we put in the DHS, how it goes, where the blade is going to go, where the plate is going to go. This was his CT scan, which we had done, how small that fracture was. We did an FNS here. In some situations, it can work. You can see that for us, luckily, the lesser trochanter was helpful for that single screw, and we were able to get a good hold into that. That's what his post-op CTs, which we got to see the reductions part. This is his follow-up. Bilateral young lady of 16 years old, metabolically had some seizures. And then 4 days later, she comes. She had gone on a picnic with a school camp. There she suffered this and came after 4 days. And here also we did a bilateral in a small, minimally invasive way and could get good union with this. But is it the best implant or the right implant? These are all honeymoon period for all of us. Now let's come to the real things. 53-year-old woman, schizophrenia on antipsychotics, hypothyroid, hypertensive. A fracture, just like the other fractures which I have shown you, but having a lot of comorbidities. We expect the bone stock to be not so good in her. She's a lady above 50 with so much of comorbidities. This was the fracture which we could reduce. After reduction, you can see that we felt that our angles and the reductions were okay. This was the fixation which we got. Any comments regarding the fixation, sir? Out there? We'll accept this fixation as we go about the reduction part. Post-op, 1 month without weight bearing. We don't know. She was on antipsychotics, whether she was bearing. From our side, it was purely like that. 1 month follow-up, 2 months follow-up. You can see the complete collapse of 2 centimeters has happened. And the head has gone just like the failures which used to happen in a DHS. It was there. All things are not so good. And this is a very common problem which is happening with this in an elderly bone quality patient. Where the bone quality is not good, the collapse is happening very fast, very rapidly, and up to 2 centimeters. And then the standard ways by which the DHS lag screw used to fail is happening. Another case of 50-year-old woman, fixed, looks okay, had an avian. And this is also considered a failure in that JOT group. So that's why I've kept this as a failure again here. The fracture is united very well. Collapse in the fracture site had not happened, but avian has happened. This is at 1 year follow-up for her. She is okay.
And has nothing to do with that implant.
You cannot say that, sir. Avian has got many things to do. That's why DHS was being considered to be a failure. DHS has got a higher rate of avascular necrosis as compared to a CC screws, 13% and 18%. That's why people came up with a newer implant to ward off the problems of a DHS. It's the lag screw fixation of rotating it. That's why they came out with the bolt. That's their USP out here, that the bolt is here, will prevent the rotation of the proximal fragment, which will reduce the chances of kinking and the stretching of the vessels, reducing avascular necrosis. So, considering that, avascular necrosis, because duration from the injury, displacements are equal for all the implants. So this will also, if we consider that, then DHS also is a good implant, because the only reason why DHS is considered to be of disrepute is because of higher rate of avascular. So that's the thing. The jury is still out. Right now it is just 4 to 5 years that this thing has come in the world market. In India, it is from September 2020 that it had come. So it's just 3 years or not even. It is just 2.5 years. There are people who are showing good results. There are people who are experiencing not the good results with us. Maybe it's the bone quality or the technique, but the reductions which I have shown you have been okay. The reductions are okay, but the bone quality is a thing which is not in our hands. The collapse rate is happening, and I think that is going to be an issue later on also regarding the collapse.
Vivek, the causes for AVN are multiple.
Yes, sir.
It's not, it is basically related to the first
I
injury.
fully agree with you. What I'm saying is, if we consider avascular necrosis as a complication in DHS, we should also consider it in,
FNS.
that's the only concern.
Now you have FNS and DHS.
So-
What would you prefer?
I'm leaving it to the audience. I will not say
Vivek.
anything like that.
I think you have probably the largest series done in the country of this because you were doing a study about it. With whatever follow-ups you have till now, what is your preferred indication to do this? Would you still endorse this implant as what has been to be?
It would be a
This is
big
to you.
statement coming from
And then I want
Deen Dayalan sir would like to answer.
Dean sir also and Dhillon sir also, because you posted something from OOS, some paper from OOS on that group.
Dr. Deen Dayalan sir.
DD sir.
No, actually, we also have done large number of FNS, but we have segregated the ones that are like good ones, like good reduction and like that. But we compared, taken out the comminuted ones separately. All the combinations where you expect to have a collapse by regular fixations, we separated it out and studied the FNS alone in those fractures. And we have found out that it was nearly like 1 in 3 was failing. That is nearly 30%. Our failure rate was 32, somewhere like the 34% by the study.
In comminuted cases or non-comminuted?
Comminuted cases. So that's why we went back to see our DHS with screws, with the same method of fixation. And you also know that we have published on the impaction bone grafting methods and things. So when we go back to the previous times, now we stopped doing an FNS in these cases now. So only in, for example, now a good bowels for you to treat, where you consider it to be a very nice one to treat, that one alone will have an FNS. Remaining will have a DHS with a screw.
That's one of the views which is there.
Using an FNS over a DHS or just because it's a new implant?
Again, sir.
Are you choosing an FNS over a DHS as a better implant or just because it is the new implant you are doing?
No, sir, now with that study, in fact, I was trying to show my WhatsApp to what I was communicating to Chetan also, that we are stopping the FNS in our, I cannot publicly say that I am stopping it. So
But exactly I'm saying. So to you, FNS is as good as DHS. So there is no need to have an FNS.
yeah, that's what.
So it is failed for which indication it was made.
If you want to have an inventory as one, it is a DHS with a screw.
The same thing is there.
Vivek,
Yes, sir.
would you say that with a high bowels, you would prefer FNS or DHS?
I would say, sir, In my experience, we have done around 65 to 70 cases now of these, which is quite a good number for 2
Yeah,
years.
type 1, type 2, you can always do DHS.
I'll just say, sir, what is the best for me? Or DHS, yes, this is a good implant technically. It's a very easy implant to put in. That's the other regarding technical aspect regarding the surgeon. Reduction is purely in our hands of the surgeons. So this implant works well in my hands if the bone quality is good. If your bone quality is not good, which is mostly, we have also tried to study our cases and above 50 and all these cases. I showed you all cases above 50, except that PPRP case. We have been more onto cases which is borderline neck femur, where we can fix it or not, and whether this implant is good or not. So in a good bone stock patient, a patient with 64-year-old male, Haryana's bulky patient with good bone stock, this will work even in Powell's 3. But if you are having a lady of 50, Indians, unfortunately, an Indian lady of 50, 51, with slight amount of comorbidities whose bones are quite osteoporotic or bone stock is less, even in Powell's 2 or 3, even in 2, this implant will give you the same collapse rate or even bit more than a DH. That's the thing. So bone quality is the main thing in my hands that works. And if you look at the literature also, the only 2 comorbidities which they look for is chronic alcohol, 1, liver disease, 3rd is chest. Why? Because they are on inhalers, they are on steroids for most of these cases, which leads to bone stock problems. If your bone stock was weak, this implant in our hands is not working. It works well. In Japanese study, it has worked well, but they were undisplaced fractures in elderly patients. So
If I can ask you the crux of it, a good bone,
every implant works. But
whether this would be better than DHS?
if in a good bone, in a Powell's 3, you are using CC screws, that is not the right implant.
I'm talking DHS.
For the audience, sir, we all know what we are saying. But for the audience, for the take-home message, I'm saying this, that if in a Powell's 3, you are taking a CC screws, it may not be the right implant. If you are using a DHS with a derotation screw for a Powell's 3, that is still the best implant in the world right now. This implant is technically easier to do than a DHS with a small amount of incisions and the work which you have to do as a surgeon. Good bone stock, it will work. Jury in my hands or in my setup, we are still deciding whether to use it in a poor bone stock patient or not.
For an Indian price of this implant, which is now available, do you feel it would be better to do this than a DHS in a good bone stock?
Yes.
Because it's a small incision, it's a much easier.
It is fair, because as soon as you put in a center guide wire, within 7 minutes, 5 minutes, you are out.
And there is one more advantage, especially in a good bone stock, that the spinning effect is more in a DHS in a good bone stock. Losing your reduction and spinning of the head is more when you have a good bone stock and you're trying to do a DHS. So actually, this is a better implant than DHS in a good bone stock.
And shaft which rotates in a left side neck femur, when the proximal fragment derotates, as soon as you tighten the last bit of your lag screw, and your reduction just moves, and you are not able to put it back because your barrel is now not going in the center part. That way it is very nice.
Another finding, Vivek, is the larger the patient, your bifurcation of the screw
Becomes bigger.
So the rotational control is bigger. The smaller the patient, it acts as single screw because it is, converging there. So I've tried to tell the Indian guy to throw in, I know you know that, just telling this, to throw in one more screw, and they can choose either anteriorly or posteriorly, which will act as an independent anti-rotation screw. So in addition to bolt and this screw, in a smaller patient, throw in one more screw.
I agree with you regarding the smaller length of the lag screws, where it is not diverging that much, giving us a good anti-rotational effect, which can be got with another.
I've discussed with Sora.